Okay, I don't know if anybody has raised this issue yet, and I don't know if it's really applicable, but as we're talking about heterogeneity in, research, I kind of want to go back to, I do research, and a lot of us have looked at, informed consent, and a lot of us know that enrollment in trials and even in research, there are still a lot of barriers and a lot of disparities in research. And so I think one thing we're really going to have to look at, too, is how are we enrolling patients and how are we addressing those disparate populations to get more of that data. And so I think that's one thing we really haven't talked about today is that enrollment, not only, we talked about like getting that reference population, but how are we really enrolling patients to address the disparate population. And I also work in pediatrics, and that's another thing. So I just would really love people in the audience to comment about that because that really affects then all the data that comes afterwards.
I will say, not to cut anyone off from making a comment to that, but one of the areas that PCORI has done a lot of work in is relatively less stringent inclusion and exclusion criteria, focusing on vulnerable populations. And so some of what we hope to do over the next couple of years is harness some of the lessons learned of how do you, for example, successfully recruit seriously chronically mentally ill patients in order to get them in trials or other vulnerable groups. So it's a very good point, and maybe others have some comments to make. Newell.
Are you keeping a list? Keep a list.
Yes, I'm sorry.
Just wanted to point out that there was a Duke Margolis FDA conference on this about 2 weeks ago, Bob, something like that. Yes, on inclusion and exclusion criteria. I think the paper should be out soon, so just so everyone's aware that there's some work already going on. I don't know, Bob, if...
Thank you.
Well, no, I don't want to talk about that. I want to talk about something else. But the paper is on its way out. I've been editing it, so I know it's getting close. Everybody agrees that a broad swath of the population with a wide variety of
Talking to the mic.
Economic and other situations ought to be in trials. One thing that hasn't come up explicitly is why we tend to put into the trials, or why companies tend to put into trials people who are relatively sick, relatively high risk.
Right.
And the reason is completely obvious. That's the only way to win. If you need a certain number of events to be able to show something, I'm assuming the effect size is the same on people who are very sick and people who aren't. But you're just not going to have enough events in the people who aren't very sick for them to do the trial that they're willing to afford to do. So usually, certainly in cardiovascular, the first study we get is in people who are relatively high risk, who have multiple risk factors and stuff like that. And if you want to know whether the drug works at all in anybody, that's the way you find out. We also encourage predictive enrichment if you can, but that's called prognostic enrichment, and it's always going to be done. So you're inevitably going to have results on the sicker population first. And
so that's a great exposition of the thinking that's dominated the way we do this research over the last 3 or 4 decades. I'd be really, if somebody has a response or something to add on to this for the 21st century, I think it at least deserves asking whether there is a different way, because that certainly is the way it's been done, and it certainly is the root of many of the problems we have when drugs get approved. So,
remember
Christine first, and
wait a minute. The first thing you want to know is whether the drug works.
We get it. That's. I think everybody in the room understands that, Bob. Okay. I would venture a guess, but it is also the problem that everybody faces when you then at the FDA approve an agent. We don't know if it works in others. Christine, and then Ravi.
So I guess I wasn't clear with what I was saying. What I was trying to talk about is the biases and the misconceptions about patients when they even hear the word research. So we were worried that our patients, pediatric patients, weren't even understanding when we approached them for informed consent, whether it was a drug study or a minimal risk study. So we used a PCORI model. We did focus groups. We did everything. We developed research videos that were health literate that addressed the needs of the patients. And the first question was, what does research mean to you? We were getting Godzilla, animal testing. We were getting all these negative things about research, informed consent. I can't say no. You know what I mean? So I think it's like we really need to somehow kind of address those issues about informed consent and participating in trials. So I guess I was speaking more general about just participating in enrollment in trials, not so much specifically about
Inclusion and exclusion.
criteria,
Yeah.
those kind of biases. So people aren't even saying no before they even know what the research is about. So we're not even, excluding patients before they
Good.
even hear what it's about. So sorry, that's
Thanks.
what I was meaning.
Another angle on the same problem of who's in the trials. Totally correct. Ravi, do you want to go next? And then Jesse, I see you in the back. And Mike. Okay.
So I think it relates to Bob Temple's comment about the trials being very selective in terms of the participants. So the obvious answer is to not be selective, but maybe not be selective in a very informed or thoughtful way, which is to sort of mimic the survey sampling paradigm. If you have a good idea of what the at-risk population is and try to sample in a way that you are representing the key subgroups or key types of people in a way that's proportional to the sample, the population prevalence, so that the evidence that you get from a trial would be representative or generalizable to the larger at-risk population. And also not only that, because the whole premise of this is that even when you do that, if you're going to come up with a single number at the end of it, it still defeats the whole purpose. Right. You're not really capturing heterogeneity. When there is heterogeneity, there is no generalizable evidence, because the evidence varies depending on the subpopulation. So that being the case, maybe thinking of next generation ways of analyzing the clinical trial data with not only the overall drug approval, which the FDA cares about, but what the PCORI cares about is how the drug does in different subpopulations. So designing the analysis in a pre-specified way such that there is more trust and reliability in the results that come out of these trials. So not necessarily recommending a specific treatment effect modeling approach based in non-parametrics or whatever. People can use whatever they want, but it has to be carefully pre-thought and pre-specified in the protocols and things like that. So in other words, expanding the current paradigm to more of a sampling paradigm plus an analytic framework that is pre-specified with HTE in mind, I think is one way to go forward.
Okay, I'm going to ask, Evelyn had a quick response, I think. Is that right? Did you have a quick response?
I did, but now I was thinking about what Ravi said.
Okay, so Jesse, and then let's keep on this point for a minute, and then Mike, and then Shelley and Ralph.
Jesse Berlin from Johnson & Johnson. First, I want to thank Katrina left. I want to thank her for letting everyone know how old I am. So I don't know. Sorry?
We didn't hear who you wanted to thank.
Oh, Katrina Armstrong. Yeah. Sorry, yeah. She left the room because she knew I was going to. Just in this whole topic of inclusion criteria, one thing I want to throw out, and I'll get to a broader point, is that there's the population you want to be evaluated for approval for a drug, and then there's everybody else. So we always throw out people with comorbidities and co-medications and whatever, but then we go to market with a drug, and we don't know anything about how that drug works in those people. So one potential model, at least, is to say, here's the population we want you to evaluate to see, does it work anywhere? Here's everybody else. Now at least we have some randomized higher quality evidence. So I think it's part, though, of a broader discussion, and I'm going to try to channel Rob Califf here for the Duke people in the room. Evidently, this may be the most important meeting, but not important enough to get Rob here. So people know that he spends the other half of his time he spends working for Google. And one of the things I've heard him say multiple times in public is that basically every time, or virtually every time you get, anyone use Google here? Once in a while? Every time you get into Google and search for something, you're part of an A-B comparison. And so I once, it's different for healthcare because you're not just shown different advertising or whatever. But his point really is that, outside of medicine, people do these experiments, these randomized comparisons all the time. And whether you knew it or not, when you clicked on some 10-page disclosure form 10 years ago, you were agreeing to be in these randomized trials with Google. So the point he tries to make, I think I'm trying not to misrepresent, is that there ought to be a way to build randomization in a kind of pragmatic way into actual clinical practice. And that's the only way. Well, why shouldn't we do it? And there's ethical discussions that need to be had. But really, the idea is to broaden, turn this into really a learning healthcare system, where you generate the results in the healthcare system, you feed them back to the people who are practicing, and I understand there are barriers to that, but he has a point.
Thanks, Jesse. I think that even ties to Christina's comment about how do we change thinking about what research is and its role in healthcare when we practice with so much uncertainty. So couldn't agree more. Shelley, and then Michael, and then Ralph.
Yeah, I want to speak to these points that you want us to, and really ask Steve and Evelyn about the possibility of combining in the same large study, let's say 1,000 people, combining a randomized trial with an observational study and sampling. Let's say there's 1,000 people at Mayo or Kaiser or somewhere, put 100 people, the same types we usually do, into the trial, and from the 900 people, you see what the models were in the trial. They'll apply to another 200 or 300, and they won't apply to another 400 or 500, but at least you'll be using the same kind of approaches, and you can see how well the predictive models work. Doing trials one after the other over a 10-year period is a loser, and as everybody's pointing out, it doesn't include most of the patients that we deal with. So I wonder if there'd be some way to put them all together. And I think the women's health study did that, didn't it? Didn't it actually do?
Mm-hmm. Oh, sure.
And the results weren't the results opposite? In other words, there was some contradiction, but at least it told us something about what was going on. So anyway, I just wondered if the two of you could talk about some ways to integrate population studies and registries, everyday practice, with randomized trials.
That's really the next most important conference. I think there's a huge, I'll just say generally because it's such a huge issue, and I want to make sure everybody has a chance to talk, that coupling analyses, observational analyses with RCTs and looking to see how predictive one is of the other is fantastically important. And it doesn't necessarily even have to be coupled with the RCT, although it could be designed in. And I know there's a lot of initiatives going on right now to try to both mimic RCT evidence with appropriately designed observational evidence. And we need to do that a lot more to learn about the domains where actually the observational data is very informative. And there are going to be other domains where it's not. And actually, one of the interesting things about the WHI was when it was reanalyzed with more modern methods, we found actually the same phenomenon was shown. So that produced a real advance in observational methods, and I predict that this coupling and more systematic coupling of observational and RCT evidence, whether it's formally done contemporaneously or even done retrospectively, is going to be probably one of the most important advances going forward.
There is another example, and pardon me for being a broken record on this, from prostate cancer, because we're working at it. There was a huge 10-year trial done in the UK, and it was quite selective, the usual thing. Then PCORI funded an observational study here. 2 years, 3 years it took? And I don't know if you funded the Chen study from North Carolina. You funded both of them. Well, guess what? First of all, the results were very similar, which means they didn't have models, but they had control variables, which were quite similar, could be built into models very easily. And the results were very similar. So even though the populations were quite disparate, and you could examine some of the differences. So I think that there It could be, but it would take a lot of engineering
Well,
that you don't want to do.
No, what I was going to say was, and very briefly, because I want to hear from other people, one of the concepts I think you're talking about is funders, particularly in the applied research field, really building bodies of evidence and thinking about knowledge development, not one study, send it out there. And we are really thinking about that very seriously. And that's one of the advantages of working with other funders internationally and nationally, is that you can begin to think about bodies of evidence and knowledge development, which is exactly what you're talking about.
I just want to mention that was done in the largest RCT ever performed. Do you know what that was? Everybody know what that was? The Salk vaccine trial enrolled millions and millions of kids. About half of them, and I can't remember the exact percentages, the states would not allow the classes to be randomized. So it was half observational, half randomized. It turned out that the observational data was almost dead on what the randomized portion was. So it was the first, one of the biggest, and it did exactly what you said. And it did it in a year with an average contribution of 30 cents per. It was not a penny that came from the government.
Okay, Michael, you've been waiting a long time.
I'll start with stressing that I very strongly believe in the importance of the health system and observational data. So, Steve, when I said the culture is not ready, or we don't have the culture, I didn't mean that we're not ready. I meant we are ready, we just need to change the mindset. And to give an example, 6 years ago I gave a talk about the risk prediction in cardiovascular prevention, the American perspective, and then Ian Graham gave the European perspective. We came to the same conclusion that risk models, it's not really what new marker to add to it, but they are not being used. 6 years right now, prognostic models, we've gone a huge leap, right? People are developing them, people are implementing them, people are using them. So let's not forget that we've come a very long way in a very short amount of time, but now the next step is starting to use them, implement it, and test it. And to the question in discussion, what do we do with the trials and how do we bridge the gap of them not being representative and applying larger populations and so on? So I have like 3 words which describe a lot of the conversation here. It's translate, embed, or mimic, right? Translation, if you have enough representation in the trial with modern methods, including machine learning, you can translate it to populations that have enough representation. And what I said earlier, what I care about is my health system, my patient, not the ones necessarily enrolled in the trial. And this can be done. So maybe a hybrid where you run it and you try to translate it if you have enough data. The other option is embed, so embedding randomization in the health system context. We've shown it, I know other large academic systems have shown, it can be done very, very inexpensively. If you have the feed of the EHR data, you can embed these trials and run them very inexpensively, and we need to take advantage of it in the context. And mimic, Steve, to your point, we have modern methods of comparative effectiveness that we don't need to be afraid anymore. If we design it, they won't always work, but we know when they will versus won't work. But we're able, in some instances, to really mimic what the trials are doing. So maybe the pathway is do it in the high risk where you have to start, right? When you decouple the equation of absolute risk reduction being the risk and relative risk reduction, focus on the risk because that's where you get the events. Make the assumption we're still making that the heterogeneity of the relative risk reduction is limited, and then test it through the appropriately designed studies.
Thank you. I just wanted one tag onto that is, in the testing of the mammoprint and Oncotype, what they did, and those were genetic risk predictors for recurrence from breast cancer. One of the trials, I can't remember which one it was, focused on that middle point that Rod pointed out. That is, the patients who were at the highest risk by the risk score did not get randomized, and nor at the lowest. It was just in the middle point where there was the most contentiousness. But that example with the mammoprint and Oncotype shows the complexity of these models, because what's happening is you can order either one or any one of the other genetic tests for breast cancer recurrence, and you may get different answers from them. So which relevant risk predictor you're in depends often what governs what a risk group you're perceived to be in, and each one costs in the many thousands of dollars.
Okay, we have a lot of hands. Rob Golub, then Ralph, Avat, Harry, Arlene, Frank. Those I know. So we'll start with Rob.
It's on? Can you? On, okay. Hi, I'm Rob Galvin. I'm JAMA Deputy Editor for Scientific Content. And I just wanted to make two brief comments and raise more issues for your agenda. First, John Spertus mentioned this morning advocating that every RCT, when it's published, should have some risk tool embedded or available so that the readers can apply it to their patients. And I'm very much a supporter of the idea that trials should somehow come up with measures of heterogeneity of treatment effect so that they can be applied. But you can't just ask journals to publish those. So if you think changing patient behavior or changing physician behavior is hard, try to change journals' behavior. You might get one journal to buy in, but you're not going to get everybody unless there is some standardization. So my argument would be this has to be moved upstream. So the protocol and the statistical analysis plan have to intentionally and deliberately think about how they're going to address this. It has to be an a priori part of the plan, and then it will be a natural to be published or somehow integrated into the publication and its dissemination. The second, kind of reacting to something that Karina said and something that you alluded to, Steve, is I'd like you to think about how to communicate these types of findings within journal articles to clinician readers. I'm a general internist, and I spent decades teaching evidence-based medicine, critical appraisal to students and to physicians, so teaching clinical epidemiology, study design, and biostatistics. And with all of my efforts, I'm convinced that most of our readers don't really understand most of the things JAMA publishes. They may understand the basic outlines of an RCT, but that's pretty much it. And we do things to try to make sure things are messaged correctly, but the reality, unfortunately, is that most of our readers really aren't going to understand how the study was designed or conducted, and may not have a nuanced interpretation of it. What we're asking for now is an even more nuanced interpretation, which I think is critical. I'm an absolute supporter of it. But I want to, as you're working on these issues, I want you to think about how can we systematically work out a way to communicate these concepts in ways that will be understandable to clinicians when the article is published. I think it's great to have tools that can be embedded in the health record or elsewhere, where a clinician can immediately get some feedback on how they should apply data, where their patient ranks. Personally, I'm not satisfied with that as a clinician. I don't want clinicians to be turned into technicians. So I think clinicians need to understand the research that's behind that. So just to add two more things to your agenda.
Thank you very much. So we have about 5 people who'd like to make comments. We have about 5 minutes. So I'm going to really ask people to be very concise. These are comments. We're not going to respond, but just want to get you on the record. Rob, you want to pass the mic to Ralph?
So I think this has been really terrific. This has been a really terrific conference, and I'm grateful to the organizers. I must say, though, that I don't think I would have called it heterogeneity of treatment effects. I might have referred to it as heterogeneity of baseline risk, because there wasn't a whole lot of discussion about actually treatment effect heterogeneity. There was the point made that if the baseline risk increases and the treatment effect is consistent, you get more event rates, but that's not really heterogeneity of treatment effects, and I wish we would have had more discussion about the topic that was advertised rather than the topic that was discussed. I do think, though, I would have appreciated, too, more discussion around this whole issue of observational research as it pertains to this, because it's not just about randomized trials. And as more and more data are now available to us about practice, we need to find much better ways of taking advantage of it to leverage the heterogeneity that exists among our patients as well as among their treatment response. I would also say that we should be much more admiring of our colleagues who are trying to push the agenda of precision medicine, despite the fact that they are hyping it way beyond its current value. Because one of the things they are doing is that they are changing the way we are measuring phenomenon. The precision and detail of measurement is changing on the biological level, at the clinical level, with digital sensors that are changing our ability to measure phenomenon there. And we need to get to that level of precision in social and behavioral variables as well. It is no longer enough to talk about zip codes. We need to talk about the impact on our patients, given that they live in certain circumstances, not whether or not the zip code is at a particular level. And finally, to refer back to Bob's point, high risk does not equate to high treatment response. And it is true that the event rate will be higher with high risk, but it will not necessarily mean that you are more responsive to treatment. So one of the questions that pharmaceutical companies need to take on is to take the concepts that you are trying to promote here into the pre-approval process. So phase 2 trials that enroll 200 or 300 subjects, get an average treatment response, and then try to extrapolate that to a 3,000 or 4,000 patient trial without looking not at the medians and means, but at the variance, is, I think, driving a lot of the problems that we're seeing in the pre-approval process. So I'd love to see this conversation taking place in the pre-approval.
Thank you, Ralph. Harry?
This is trying to actually bridge what Bob said, which we clearly understand, and also, though, Joe, what you said about, and also getting broader effectiveness trials, which also then allow for us to study the heterogeneity of treatment effect. And that is, and Newell's gone, but Ralph DAgostino is still here. He was in this, so I represent him and these two, and Norman Stockbridge from Cedar, and a couple others where we came up with a design called the E to E design. And it starts with the efficacy study and then seamlessly transitions to an effectiveness trial where it goes much broader, and thereby we hopefully will be able to study all the matters of heterogeneity. The interesting thing about that is the struggle between the payers who would like to know that kind of information, the drug companies who are afraid of the signal-to-noise ratio deteriorating. And we've also come up with other models called the EE2. You do them at the same time. I won't go into those right now at all, but I will just say that it's something that is very much in the wheelhouse of what PCORI should be thinking about, which is drawing and we had broad stakeholders involved, and we're making some progress, but it really would, in fact, stop us from having the circumstance, like, for example, with asthma inhalers, where their first trials and where they got their label was basically in about 5% of all those who use it. So I think a lot of us are really worrying about that, and it's obviously a key point. And the problem was then to make predictive models out of that data.
Yeah, thank
Harry, thank you. Frank. Then Arlene, and then Iwad.
So I want to echo what Ralph said, that risk magnification is not HTE. It's a lot easier to study, and you don't always need any data to actually do the calculations of the expansion of absolute risk reduction. So it could accompany any clinical trial for free, almost any. And then I think one thing we didn't spend enough time on, which Ralph said this another way, is the foundations of true HTE. So if I channel Stephen Senn, S-E-N-N, he's written the most elegantly about this and talked about where the idea came from, which really is FDA and the physician's desk reference. It's a very interesting story, and it started off on the wrong foot. But I think in terms of foundations of HTE, there was a paper that came out months ago, and I forgot the reference, but it's the sort of thing we need to know more about, which is they took a meta-analysis of lots of clinical trials where there was a continuous outcome variable. And they said if HTE is really rampant, the variance within the placebo arms should be lower than the variance within the treatment arms, because this shouldn't apply to placebo patients. And they didn't find that at all. So based on a meta-analysis, the existence of HTE is very limited. And the number of examples that have been validated where HTE really exists is very limited, except in some molecular situations. But I think we need to spend a little bit more time on the foundations of true HTE.
Okay. Good point. I think the organizers of this appreciated the difference between the two types of I'll call them treatment heterogeneity pretty well at the outset. And this was really clearly much more about the risk-based differences in treatment impact, which are absolute rather than relative risk differences. And so your point is well taken. Nonetheless, this is probably more important to be talking about than that, just because it affects every decision that clinician and patient make. Arlene, and then Evat, and then back to David for the real close.
So I'm going to move way downstream. So the trials are used to do systematic reviews, which go to guidelines, which go to quality measures. And I think we need to figure out ways to communicate this uncertainty and heterogeneity across all of those. And maybe one way to start is by really thinking about different ways to do systematic reviews to reflect some of this uncertainty. Yeah, and that might be an easy place to start. My second comment is about dissemination and implementation, because none of this matters unless we're getting it to patients. And we heard, with the patient panel, patients aren't getting what they need. So I think we need to design studies to really try how do we incorporate this in an efficient way in practice, where patients and clinicians can have these meaningful discussions in a way that helps everybody. And I'm just going to throw out a suggestion. ARC has a capacity through its action network to do some rapid cycle prototyping, piloting, and maybe that's a place to test some different implementation strategies around complexity.
Thank you, Arlene, and excellent to have the voice of ARC here in the meeting.
Well, thanks. It was a great day and difficult to add anything new, but perhaps I was really focused on decision making. So do we make better decisions? And I would disagree with the issue of the effect. I mean, as David started the morning, absolute risk difference is the effect for an individual to me. So is that better estimated with all the things we have been talking about today than just taking the average effect? And let me comment on two things. This risk concept that Steve referred to as fundamentally not known, and you need to estimate that and approximate that. So the basic thing, and that was also what Michael, what you were saying, the thinking cardiovascular prevention risk is really just absolute risk prediction, and then you assume that the benefit is larger with statins and other interventions if you're higher risk. So that's really the basic thing you would think is better than not using risk modeling, whatever way you do it, and might be one thought. Whether we do better by then allowing for interaction and say in the other sense, effect modification, differential effect, responsiveness differences, that's to me a question like bias versus variance, that variability will increase in the estimation process. And that same bias-variance trade-off is when we think about using observational data, as you also commented on, Steve. And so I think that is really a topic for further research on finding that balance, either more case studies. David, you published 32 trials, reanalyses or so. Well, if we do 3,000, are we convinced, or I'm in doubt there how we should move on, and maybe some theoretical work can be done in that area. So that's on the risk concept, and I was thinking, do we make better decisions? And all there is on the implementation and the presentation. So there, I think with the pharmacogenomic presentation we heard, that is relatively straightforward, that you really think there is a mechanism that someone is not metabolizing a drug like another one. So you really have this genotype with a very clear subgrouping. So Frank, there you will agree with me that you make groups. Right? And you will not agree with me what is very successful in oncology, where since years we present these models as good, intermediate, and poor risk and differentiate treatment by this grouping. So prognostic grouping is very common in oncology and very successful in the implementation. All these trials are for poor risk patients or for good risk patients. So you may disagree from a principle perspective that it's better to have continuous risk. But there it works very well. So that's on the implementation. And maybe the ideal case then would be something like electronic patient records, where these tools are implemented, and then you can go anyway, whatever complexity of the underlying model. So these were some thoughts for your consideration.
Thanks, Ivan. Okay, so once again, thanks on behalf of PCORI to all of you for attending today. And David, I'm going to turn it back to you to untangle all this.